All right, well, I think we will get started. Good afternoon, everyone, and thank you for joining us for NCS Pharmacy Section Journal Club. We have two excellent articles that we're going to discuss here. The first one, as you can see, focused on beta-lactam neurotoxicity in the critically ill. The cool thing about this is it's also our Twitter journal club that we typically do, so you can follow along on Twitter to keep the conversations going using both hashtags of hashtag NCSTJC and hashtag NCS Farm Journal Club, or excuse me, Farm JC. I'm Kimberly Lavasser Franklin. I will be your moderator for the remainder of the Journal Club. If you have questions, please feel free to put them in the chat. Our first presenter is Kelsey Habergorst from University of Texas Southwestern Medical Center. Go ahead, Kelsey.
Hi, yes, thank you for that introduction. Like Kimberly said, my name is Kelsey. I'm the PGY2 critical care resident at University of Texas Southwestern. Today, we will be discussing the article Incidence and Predictive Factors Associated with Beta-lactam Neurotoxicity. And specifically, we're going to be looking at those in the ICU. So first, we will review the proposed pathophysiology as well as the existing literature relating to beta-lactam neurotoxicity. We will then focus in on the article we'll be discussing today, looking at the primary conclusions that this article found, and also discuss ways that we can implement this into our daily practice. Starting out, we all know that drug-resistant organisms are very problematic for our patients, all hospitalized patients, but specifically those who are in our ICUs. Whenever we think about these organisms, one of the bacteria that probably comes to mind is Pseudomonas, as that is a common drug-resistant bacteria that we see in our ICUs. Beta-lactam antibiotics are among the most common utilized in order to treat these types of infections. So that will be our focus today, is our anti-pseudomonal beta-lactams. Beta-lactams are generally well tolerated. You can see on the screen the common side effects that are seen. So they can impact our blood cells. They can cause hepatotoxicity. Like many antibiotics, they will disrupt our microbiome, and so therefore that puts patients at risk for C. diff infections. A lot of these beta-lactam antibiotics also have the side effect of nephrotoxicity. Mitochondrial toxicity is another side effect sometimes seen with these medications. And then we know all too well the beta-lactam allergy that many of our patients face. However, the focus of our presentation today will be on specifically the neurotoxicity aspect of the beta-lactam antibiotics. So it has been shown that about 7 to 23% of our patients in the ICU will experience beta-lactam toxicity and neurotoxicity. And this range is very wide, most likely because the side effects are variable. So some patients might see, decreased level of consciousness, confusion, encephalopathy, but other patients might experience more severe side effects. So things like myoclonus, seizures, non-convulsant status epilepticus, hallucinations, and some will experience EEG changes as well. The proposed pathophysiology of how beta-lactams cause neurotoxicity is depicted in this image. So you can see the top image here, image A. This is how this is a normal physiology. So you can see the GABA molecule where it binds on the GABA receptor, as well as the benzodiazepine molecule and the benzodiazepine binding site. Whenever these molecules bind to the GABA receptor, it causes an influx of chloride. And that kind of helps our checks and balances with our neurons in order to make sure they are not too excitable. So this influx of calcium really reduces our neuronal excitability. However, if you look at the bottom image, image B, you can see whenever the beta-lactam is present, the beta-lactam ring itself is structurally similar to our GABA molecules that are in our body. So the beta-lactam will bind to the same location as the GABA molecule does, and that causes the GABA molecule to not be able to bind at that site. So therefore, you will not have a chloride influx, and you will actually have an increase in neuronal excitability. So when we have this more excitable state, that's what leads our patients to experience these side effects that we just discussed on the slide previous to this. One way we can try to eliminate or at least reduce the patient's risk for developing not only neurotoxicity, but any of those side effects that we discussed is trying to make sure they're in the target drug concentration range, which you can see in the image on the screen here. Therapeutic drug monitoring really allows us to have a better idea of where our patients fall on this list. And it helps us prevent not only toxicity, but also resistance and clinical failure. A lot of the beta-lactam antibiotics have a one-size-fits-all way that we dose these. And this is probably okay for majority of our patients. However, whenever patients are in the ICU, a lot of their PK can be variable. So this would be a way that we can better identify patients who are at risk for these levels being out of range. Unfortunately, there isn't a well-established threshold for beta-lactam therapeutic drug monitoring. However, there is more and more literature coming out, so I think that this will be something that we can utilize in the future. Looking at the previous literature that has looked at beta-lactam neurotoxicity, the first article we will discuss is one that was done in 2003. This was a retrospective observational single-center study, and it looked at patients who developed neurotoxicity either secondary to cefepime or ceftazidime exposure. And they were looking specifically at the characteristics of their neurotoxicity as well as the onset. So they found that 93% of these patients with documented neurotoxicity experienced confusion and 29% experienced myoclonus. Some of them did have EEG changes, and how that showed was a loss of background activity. All of the patients who experienced neurotoxicity did have some degree of renal impairment, and the median time to onset of symptoms was about 5 days. The good thing, though, is that all of the patients' symptoms were reversed once the antibiotic was discontinued. In 2013, Fugate and colleagues also looked at a retrospective observational single-center study. This one was focusing in on the ICU patients who were receiving cefepime for greater or equal to 3 days. And they were looking at, again, what type of symptoms that they had and the dose of cefepime that was used. So they found the median dose of cefepime was 2.5 grams per day. And again, the most common side effect, or I guess I should say the most common way that they exhibited the neurotoxicity was impaired consciousness, followed by myoclonus, disorientation, and one patient did have non-convulsive status epilepticus. Cannon and colleagues published a meta-analysis in 2014, and this study included all randomized controlled trials from January 1966 to November 2013. And this one was looking specifically at seizure activity, and they were comparing carbapenems to non-carbapenems. So if you look at the results section of this table, you can see the first column there is all carbapenems compared to non-carbapenems. And you can see that there was a significant increase in seizure risk among those who had carbapenem exposure. The next two columns are looking at imipenem and meropenem compared to non-carbapenems. The imipenem group, you can really see they had a higher incidence of seizure, having 61 patients experience seizure who had imipenem compared to 17 of the non-carbapenem group. Whereas the meropenem group in the third column there, you can see was very similar, 30 compared to 29 in the non-carbapenem group. The last column, imipenem compared to meropenem, there was significantly higher patients in the imipenem group who did have increased seizure risk. So the takeaway from this slide is that yes, our carbapenems do have an increased risk of seizure, but the main culprit of our anti-pseudomonal carbapenems is definitely going to be imipenem and not so much meropenem. Sutter and colleagues published a systematic review in 2015. This one included studies that were looking at seizure activity among all antibiotics, and this was done from 1960 to 2013. The association that they found between symptomatic seizure activity and the antibiotic exposure was actually pretty low. They categorized it as low to very low. The most common antibiotics that did have the increased risk of the seizures were fourth generation cephalosporins, imipenem, and ciprofloxacin. The predisposing factors that patients had was renal dysfunction, brain lesions, and history of epilepsy. So up till this point, the literature that we have provided has shown us that a longer duration of beta-lactam use can increase our risk factor for developing neurotoxicity, along with renal impairment, underlying neurologic abnormalities, as well as advanced age. So now that we have a good idea of the previous literature that has been published, let's dive in a little bit closer to look at the article we'll be discussing today. The clinical objectives were to first determine the incidence of beta-lactam neurotoxicity, and then they also wanted to derive and validate a multivariable prediction model so that we can better assess which patients who are coming into our ICU are at risk for developing beta-lactam neurotoxicity. So that's a good point that I wanted to point out, was that the authors really wanted to use variables that would be accessible to the providers upon admission into the ICU. This study was a retrospective cohort study, and it was looking at patients with anti-pseudomonal beta-lactam antibiotics. So those included piperacillin, tazobactam, cefepime, and meropenem. This study was done at Mayo Clinic Hospital, and it included patients who were admitted to the medical and surgical intensive care units. They had two different pools of data. They had their derivation cohort, which was done from January 2008 to September 2013. And then their validation cohort was from January 1st, 2018 to December 1st, 2020. To be included in this study, the patients had to receive one of the study medications for at least 48 hours, and they could not have received another beta-lactam antibiotic within the last week of the course of interest. Patients were excluded if they were admitted for a neurologic reason, so that would be something like alcohol withdrawal, hepatic encephalopathy, dementia, epilepsy, drug overdose, stroke, TBI, things like that. They were all excluded. They were also excluded if patients had documentation of delirium. So this was evidenced by a positive CAM-ICU score, a GCS less than 8 within 48 hours of the beta-lactam initiation. Those who were on continuous paralytics or had benzodiazepines, which was defined as equivalents of 20 milligrams of lorazepam per day within 48 hours of beta-lactam initiation. And then lastly, they excluded patients who were pregnant, incarcerated, or unable or unwilling to consent to use of their medical records. So after being screened based off of the antibiotic that these patients were on, they were then looked at for specific diagnosis codes or terms that were used in their medical chart. So these terms included things like cognitive impairment, altered consciousness, seizure, confusion, neurotoxicity. The whole list is included there on the screen for you. After that initial screening, there went to a manual triplicate review, which was done by 2 clinical pharmacists and 1 neurointensivist. And this was done using the Naraho adverse reaction scale. And so this included things like the onset and duration of the antibiotic. They also looked at alternatives for the symptoms that the patients were having. So looking at the if the patients had elevated BUN, ammonia, abnormal electrolytes, if they seemed to be overly sedated, things like that, this scoring tool took into account. They also looked at the confirmation of the adverse drug reactions. So this could be evidenced by either EEGs or having myoclonus or seizures documented in the medical chart. For statistical analysis, the continuous data was depicted with means with standard deviation, median, and interquartile ranges. A Kaplan-Meier curve was utilized to assess the timing and cumulative incidence of neurotoxicity. And then a univariate and multivariate logistic regression model was done to identify the potential predictors of the adjudicated neurotoxicity. For the creation of the actual prediction score, they had the derivation cohort, which allowed them to identify which risk factors to include. And then that was tested in their validation cohort. They also used a C statistic to determine discrimination in the predictive model. So the C statistic ranges from 0.5 to 1, 0.5 showing poor prediction, and then 1 showing a perfect differentiation between positive and negative outcomes. They utilized the area under the precision recall curve for further characteristics and the frequency of positive cases. And this was done because they had an expected large number of true negatives. The Hashmer-Lehmann-Show test was used to assess the calibration of the statistic model. For the enrollment in the study, they reviewed 2,562 patients for the derivation cohort. Most commonly, these patients were excluded because they had an alternative reason for altered mental status. Some of them did have were deeply sedated or had a positive CAM-ICU score, or they were on IV, another IV antibiotic. So 1,323 were included in the final derivation cohort. For the validation cohort, they had 7,175 patients that they screened. Most commonly, these patients were excluded because they received another IV beta-lactam, or they had an alternative reason for altered mental status. So in total, 767 were included in the final validation cohort. Baseline characteristics were similar between groups, with the average age of 65-year-old men with median Apache 3 scores of 71. The estimated creatinine clearance in both groups was 75, and a breakdown of the beta-lactam antibiotics that the patients were on are here on the screen. So you can see piperacillin tazobactam had the largest portion of the patients who were included in this study. The derivation cohort had 39% of patients who received piperacillin tazobactam, or 32% with cefepime and 29% meropenem. In the validation cohort, again, piperacillin tazobactam had the highest percentage at 61%, cefepime at 37%, and meropenem with only 2%. For the incidence of neurotoxicity in the derivation cohort, after initial review, 12.3 tested positive for neurotoxicity, but after the triplicate manual review, that narrowed down to 2.6%. And then similarly in the validation cohort, 25 tested positive initially, but then after manual review, 2.1% ended up being positive for neurotoxicity. The median time to symptom development was approximately 2.5 days, which is similar to what we've seen in previous literature. As far as the incidence based off of the specific antibiotics, cefepime had the highest incidence at 41%, followed by piperacillin tazobactam at 35%, and meropenem at 24%. The risk factors that were identified based off of the derivation cohort was having a higher weight, higher BMI, a higher Charlson comorbidity index, and being older age, all were statistically significant in those who had neurotoxicity. And then the other one that the study included is the estimated creatinine clearance. Although this wasn't statistically significant, there was a clinically significant difference at 14 mLs per minute between those who did not have neurotoxicity and those who did have neurotoxicity. For the validation cohort, the best performing model did have a C statistic of 0.62 and a AUPRC of 0.04. So the scoring tool you can see on the screen in blue is what they came up with. So it included age, weight, Charlson comorbidity, and estimated creatinine clearance. And you can see Charlson comorbidity was the highest weighed out of all of the variables. They also identified 35 as the score cutoff for the prediction model. For the strengths and limitations of this study, some strengths include that each of the patients who screened positive for neurotoxicity were then manually reviewed utilizing that standardized adverse drug reaction Naraho scale, which I think is a definite pro of this study. Another strength is that the author's conclusions were supported by the results. Patients who were had other reasons for neurotoxicity were excluded. And I think this is a really good point because it's very difficult to truly assess the patients who have neurotoxicity due to a antibiotic compared to other reasons that they might have just based off of being in the ICU setting. The goal of the trial was to create a prediction score that could be utilized upon admission to the ICU. And I think the authors did a great job of that. All of the variables that were included were things that would be available to the practitioners upon admission. And the dosing was appropriate based off of renal function in both the validation and the derivation cohorts. The limitations of the study are that it was a single center observational retrospective design. The derivation and validation cohorts were done in very different time frames, which I think can make it difficult to truly assess because of many reasons. One being that documentation might have been a little bit different in the past compared to the more recent future. And then there's been an increase in antimicrobial stewardship programs, so that could have impacted, the differences in the patient population, specifically looking at the percentage of patients in the validation cohort that were on meropenem only being 2%. They did have limited external validity since they only included patients who were in the surgical and medical ICU. And the other thing found interesting was that the average creatinine clearance was 75. And I don't think that would be the average creatinine clearance at my institution. And I would guess that would be similar at other institutions in the United States. Identifying patients with true beta-lactam neurotoxicity, while I did mention this in the strengths as well, I think it's really difficult just based off of the heterogeneity of this population and how they present. So some of the previous literature included things like somnolence, headache, and other symptoms that would categorize patients as having neurotoxicity, whereas this study was very specific. The beta-lactam that they looked at, or most commonly was included in the cohort, was piperacillin tazobactam, which has very limited data as far as causing neurotoxicity compared to cefepime and meropenem. So that was another drawback that I found. But overall, the study showed that the incidence of beta-lactam-induced neurotoxicity was about 2 to 3%, which is much lower than previous literature, but I think this is because of their strict inclusion criteria. And the risk factors that they found were advanced age, higher weight, higher Charlson comorbidity index, and a lower creatinine clearance. I think that we can improve our external validity by doing more larger multi-center studies in the future. Right now, it seems like this neurotoxicity is a diagnosis of inclusion, ruling out other causes of neurotoxicity. And then further research should be done in order to determine what therapeutic monitoring levels can be assessed for beta-lactam antibiotics, so we can have a better idea of who is truly experiencing this neurotoxicity. And with that, I will answer any questions that you all have.
Nicely done, Kelsey. Just a reminder to folks, certainly feel free to either enter your questions into the chat. Also, just a friendly reminder to make sure that you're on mute as we continue forward with the discussions. I do have one question in the chat that I'll start with, and then I have a question from my own, but this is from Bree Zinzer. The question is, as a neuro ICU pharmacist, since the majority of my patient population was excluded from this study, can I utilize the study's results in my clinical practice?
Yeah, I think this study definitely gives us a good insight into patients who are at risk for developing neurotoxicity, even if it's not patients in the medical or surgical ICU settings. I think that this can be kind of taken into different areas of the hospital as well. Now, obviously in the neuro ICU, we have a lot of other factors that come into play whenever we think of them having neurotoxicity. So really narrowing down, like I mentioned with the diagnosis of exclusion, I think that is a bigger impact in the neuro ICU, since they have a lot of other reasons why they could have neurologic deficits. But overall, yes, I think that you can still utilize this study.
All right, some follow-up questions. This one, Kent, I'll get to your question in a second, but this first one from Dr. Aaron Barretto. How does the incidence in the study match with your clinical experience? Is the 10 to 15% that's previously cited close to what you see, or is it more in the 2 to 3% so far that you've experienced?
Yeah, so with my very limited experience, I would say that my experience is probably closer to what this study has found. Now, again, I have only been practicing for 2 years, so I don't know how much I can truly say, but out of all of my ICU rotations, I think I've only had maybe 1 or 2 patients who had true beta-lactam neurotoxicity. So I think my practice would fall more in line with this study.
Fair. And then the question from Kent Owosu, were you surprised at the findings of neurotoxicity rates among these agents? He says the number seems higher than what was previously reported, and it seems non-convulsive status epilepticus is generally common with cefepime versus other types. Can you comment on the occasional EEG monitoring or other limitations you think may have influenced the findings?
Yeah, that was probably my biggest surprising point, was that the most common antibiotic that they assessed was piperacillin tazobactam. And I don't know about other institutions, but a lot of providers at my institution will actually switch from cefepime to piperacillin tazobactam or to prevent the neurotoxicity. So that was probably my biggest surprise from the study. And I think it would have been nice to see more patients with cefepime and meropenem included.
Yeah, fair. And to echo what you said, Kelsey, similarly, I have some attendings here on our medical side who will switch to Pip/Tazo over cefepime if they're concerned. So it's interesting. We probably have time for one more question, but the conversations and discussion in the chat are awesome. So people please keep add them onto the Twitter feed using the hashtags that are in the chat. But last question here from Kyle Blaylock. Do you think it is possible these drugs have a higher incidence of neurotoxicity in comparison to other beta-lactams because the drugs potentially cross the blood-brain barrier more?
Yeah, that's a fair point. I do think that those antibiotics who cross the blood-brain barrier are going to have an increased risk for neurotoxicity compared to those who maybe don't cross the blood-brain barrier as much. Yes, I think that specifically your meropenem and your cefepime would definitely have a higher risk, I would think, for neurotoxicity.
Fair enough. Well, again, thank you for that excellent summary and assessment on that literature. Again, if folks still have questions directly for Kelsey, feel free to put them in the chat. Otherwise, also tweet them. We're going to switch gears and focus a little bit now on the NORTEST trial. If the next presenter wants to go ahead and share their screen. This presentation is being given by Angud Sodhi. He's the PGY2 critical care resident at the Ohio State University Wexner Medical Center. So welcome, and we will wait for him to get settled. For this article, you can also, again, follow on Twitter and hashtag NCSPharmJC. And we look forward to hearing about tenecteplase. Go ahead, Angud.
Thank you. Thank you for that introduction. Like Kimberly mentioned, my name is Angud Sodhi, one of the critical care residents at the Ohio State Wexner Medical Center. And today I will be presenting on the NORTEST-2 trial. So I know that tenecteplase has come up multiple times, potentially as a replacement for alteplase, but we will dive into the literature a little bit to see if that's the case, or maybe there's a turn of direction here with the results of this trial. So this is a list of just a few abbreviations that will be used throughout the presentation, some more of the common abbreviations used in the neurocritical care world. And I'll go briefly into a background for the thrombolytics. So this is an image that I found very helpful to visualize the mechanism of action of tissue plasminogen activator. So essentially, in the presence of a fibrin-rich clot, we have endogenous TPA that is released that helps convert our plasminogen, which is a protease enzyme, into plasmin, so that in the presence of TPA, we'll have plasmin basically activated, and it will bind to a fibrin-rich clot and help break that fibrin-rich clot down into fibrin degradation products. And then in essence, the fibrin degradation products will then be taken out of the body in its own way. But there are presence of some plasminogen activator inhibitor, as you see on the left in this box here. And then there is also alpha-2 antiplasmin, which will bind up plasmin as well. So that will prevent the further breakdown of fibrin products in the case that would lead to more bleeding. So there is like that homeostasis balance, which we will talk a little bit more about when we talk about the potential pros of tenecteplase. So historically, for acute ischemic stroke, alteplase has been the drug of choice. In 1995, the NINS trial was published that showed that alteplase was a benefit in acute ischemic stroke patients, specifically within 3 hours of symptom onset. And they found that patients had an improved functional outcome, which was defined as an MRS of 0 to 1 at 90 days. So we saw more long-term benefit in the patients receiving Alteplase. But they did find that there was more intracranial hemorrhage within 36 hours of symptom onset and getting the drug, as well as, sorry, I have a pop-up that just came on my screen. I apologize. And major intracranial hemorrhage was also seen at 3 months after treatment. Subsequently, the ECAS-3 trial was published in 2008. And this looked at the same drug Alteplase, however, within an extended duration of giving the medication from symptom onset. So this was within the 3 to 4.5 hours of symptom onset. Initially it was 4, but because of recruitment issues, they extended it out to 4.5. And they also found similar outcomes to the NINS trial with the improved functional outcome with the same MRS 0 to 1 at 90 days. But similarly, they also found more intracranial hemorrhage and symptomatic intracranial hemorrhage compared to the NINS trial and compared to placebo in the trial itself. So moving into tenecteplase versus Alteplase. So there are some theoretical benefits of tenecteplase. Essentially, it's a genetically modified tissue plasminogen activator that has been approved to be used in ST segment elevation myocardial infarction. So the picture on the right is the tenecteplase molecule, but it actually is the same as, almost the same as the Alteplase molecule, other than the 3 green dots, as you see here, I should say 3 green sections. So I have matched up the differences between Alteplase and tenecteplase and what their theoretical advantages are with those individual changes. So at section 103 in the Alteplase molecule, that's actually replaced by the threonine in 103 is replaced by asparagine at this section, and that's linked with the longer terminal half-life in tenecteplase. For the section 1 or spot 117, the asparagine molecule in Alteplase is replaced with glutamine, and that's associated with the higher resistance to the plasminogen activator inhibition. And then farther down the molecule, all the way on this right side here, we have a sequence of amino acids from 296 to 299. And those amino acids are replaced with the tetraalanine structure, and that has been associated with the higher fibrin specificity. So these are some of the theoretical advantages of tenecteplase over Alteplase, but we will get into some of the more functional benefits or outcomes compared to Alteplase. So these are 3 trials that I would like to highlight. These were all phase 2 trials, although the first trial was a combination of a phase 2b with a 3, but I've only highlighted the outcomes from the phase 2 trial. So the first trial was published in 2010. It was a phase 2b/3 trial looking at tenecteplase in acute ischemic stroke. And they looked at 3 different doses of tenecteplase. So they looked at 0.1 milligrams per kilogram with a max of 10, 0.25 milligrams per kilogram with a max of 25, and then a 0.4 milligrams per kilogram with a max of 40. And essentially, the reason why I highlighted the 0.4 milligrams per kilogram is that when they were assessing the intracranial hemorrhage rate, they had to stop the recruitment early for those patients because of the drastic difference in intracranial hemorrhage. So they stopped recruitment at about 19 patients, but the other 2 groups achieved about 31 patients in each group. And on the right, you can see that compared to placebo, there was a 45.2% good functional outcome, which they defined as an MRS of 0 to 1 with a 9.7% ICH rate in the 0.1 milligram per kilogram. We have a little bit of an increased rate and good functional outcome with a 0.25 milligram per kilogram, albeit with a slightly higher ICH incidence. But as you can see in the 0.4 milligrams of those 19 patients, they did report a lower good functional outcome incidence, but a much higher intracranial hemorrhage outcome. Going into the second trial, this looked at and published in 2012, this looked at tenecteplase versus Alteplase, again in acute ischemic stroke. And they looked at 2 doses with the initial findings from the 2010 study showing that there was a high rate of ICH. They did not study 0.4 milligrams per kilogram. So they looked at the 0.1 milligram and 0.25 milligram per kilogram doses, and they compared that to the standard dose Alteplase that we utilize in acute ischemic stroke patients traditionally. In their findings, they found that the tenecteplase was associated with better reperfusion on imaging, statistically significant difference, and they did show more improvement in the NIH score at 24 hours. which is a highlight because some of the Alteplase studies did not show that major improvement at 24 hours. The major findings of those studies were more of the functional outcome at 90 days. There was a breakdown of 25 patients in each group of the tenecteplase groups and 50 patients in the Alteplase group. However, they did combine the groups. So they essentially took the tenecteplase cohort and combined them and then compared it to the Alteplase cohort. And they didn't find any difference in functional outcome at 90 days, but when they broke down the groups into the individual doses, they did find that higher dose tenecteplase, the 0.25 milligrams per kilogram, was associated with excellent recovery, which was defined as an MRS of 0 to 1, but the functional recovery in general, which was defined as 0 to 2 on the MRS scale, there was no difference between the two and Alteplase. And they found no difference in any of the safety outcomes related to intracranial hemorrhage, whether it was all intracranial hemorrhage or symptomatic. And then finally, I'd like to highlight the ATTEST trial, which was published in 2015, again, another phase 2 study. And they solely looked at the 0.25 milligram per kilogram dose and compared that to standard Alteplase. And notably, they found no difference in any of their imaging outcomes, their clinical improvement at 24 hours, or any of the functional outcomes long-term. And they didn't find any difference in ICH. So although there was no safety difference, it kind of contradicted some of the previous phase 2 studies that did show that improvement at 24 hours and that improvement at 90 days on the MRS scale. So we'll go into the 2017 study, which was a phase 3, the NORTEST study that looked at patients that presented within 4.5 hours of symptom onset or within 4.5 hours of awakening with symptoms, or dubbed as the wake-up stroke. And the patients had to have been living independently prior to the stroke onset. Essentially, what this study looked at was their primary outcome was the substantial reperfusion that was defined as the restoration of greater than 50% blood flow, or if they were doing their angiography, if there was no retrievable thrombus on their first imaging. The reason why I did not highlight that is because I wanted to compare more of the long-term data with the other studies. So they compared the TNK 0.4 milligram per kilogram dose. Although it was shown that there was a higher rate of ICH, they did want to see if this was more beneficial in these patients, and compared that to the standard Alteplase. The patients that did present had a median NIH stroke scale score of about 5. So this would classify them as more of the minor ischemic stroke patients. And greater than 70% of those patients did present with the mild acute ischemic stroke. And then the median time to thrombolytic therapy for this cohort was about 2 hours. I mean, that's going to be something to highlight moving forward, because although the patients that were included were up to 4.5, the majority of the patients received it within 2 hours. And then they did present their data as a median with interquartile range, and the higher range at the 75% did not expand beyond 3 hours. And then looking at their long-term data, they found no difference in the MRS at 90 days. And they also did not find any difference in any ICH or symptomatic ICH at 48 hours. So this again shows that a little difference in that first phase 2 study that showed a high rate of ICH and ICH in general. So this was bringing the 0.4 milligram per kilogram dose back into question whether it was something that we could utilize for these patients. And then the last phase 3 trial that I'd like to highlight before we move into NORTEST 2 was the Extend IA-TNK trial. And this study looked at patients that had specific strokes, so occlusion of their ICA or their first or second segment of their MCA. And they also included patients that had basilar artery strokes, and they had to have presented within 4.5 hours of symptom onset. All the patients that were included must be eligible or had to have been eligible for thrombectomy, and they used a mismatch ratio of 1.2. This is a little different than what we utilize at Ohio State, which we use a ratio of 1.8 on imaging to determine the eligibility for thrombectomy. But they did utilize the TNK dose of 0.25 milligrams per kilogram with a max of 25 compared to standard dose Alteplase. The patients that were included here did have a higher median NIH stroke scale with about 17 compared to the 5 in the first NORTEST study. In the greater than 50% of the patients that presented did have the first segment of their MCA included. And then similarly to the NORTEST trial, the median time to thrombolytic therapy was 2 hours. And then the arterial puncture for thrombectomy occurred in about 40 minutes after the drug was given. So for their outcomes, they found that the TNK group did have substantial reperfusion, which similarly defined in the first trial, which was greater than 50% restoration of blood flow. And it was statistically significant. And then in their secondary outcomes, they did find long-term data supporting a good functional outcome, which again was defined from 0 to 1 in the TNK group with a p-value of 0.04. And then for their safety data, they also found that there was no difference in any symptomatic ICH or parenchymal hematoma between the two groups. So essentially the takeaway from this study is in a specific subset of patients, the patients that qualify as large vessel occlusions, that patients are eligible for thrombectomy, that tenecteplase may have a role in these patients that support giving it with as an adjunct therapy with thrombectomy. So the NORTEST 2 trial, which was published earlier in 2022, the goal of this study was to establish non-inferiority of tenecteplase at a dose of 0.4 milligrams per kilogram compared to alteplase standard dose for patients with moderate or severe ischemic stroke. So this was a phase 3 multi-center randomized open label blinded study that was conducted across 11 hospitals in Norway. And for their inclusion criteria, patients had to have been at least 18 years of age, living independently prior to stroke. And again, very similar to the other studies, had to have been admitted within 4.5 hours of stroke onset. Because they were looking at the moderate or severe stroke, patients had to have had an NIH stroke scale of at least 6 on admission. And they did include wake-up stroke patients, but if they were deemed to have a wake-up stroke or an unknown onset, the MRI scale or the MRI scan had to have showed a mismatch prior to their inclusion into the study. And then for the patients, they obviously had to have been eligible for thrombolytic therapy, but this, of course, was based on Norwegian guidelines. I did not go in specifically into them, but very similarly match up with the guidelines that were established with the NINDS and ECAS trials for alteplase, at least. And then for their primary outcome, they looked at functional outcome again at 90 days. So this was an MRS of 0 to 1, or if they did present, if they had a pre-stroke scale of 2, we were looking for a return to baseline. And then they looked at a variety of secondary outcomes, mostly at safety outcomes. So they looked at any ICH that occurred within 24 to 48 hours. And then they also looked at MRS of 5 to 6 at 90 days, with 6 being death. And then they looked at death alone at 90 days. And then for some secondary efficacy outcomes, they looked at major neurological improvement at 24 hours and an ordinal shift analysis of our MRS score at 90 days. I think this is a good point to make out for the ordinal shift analysis. This allows a variety of MRS scores to be included in their analysis rather than just looking at the primary outcome, which was 0 to 1, or just if they return to baseline for 2. So like mentioned before, they did look at that 0.4 milligram per kilogram tenecteplase dose compared to the standard dose alteplase. And they collected NIH stroke scale scores at baseline, at 2 hours, and then they looked at 24 to 48 hours and at 7 days. So the MRS scores were collected at 7 days, and this was done to the best of the provider's ability at the bedside. And then they updated the MRS scores from family information, or if the patient was able to, they would update the scores based on the information they provided as well. And of course, at 90 days. And then they chose a non-inferiority margin of 3% based on prior studies, assuming an absolute difference of 8.7% between alteplase and placebo. The reason why they chose the 3% non-inferiority margin is because it does maintain the lower end of their confidence interval from this previous studies of about 6%. So I thought that this was an appropriate non-inferiority margin to select. And then something I found very interesting was the study group did perform safety reviews after enrollment of every 200 patients. And then any patient that presented with an NIH stroke scale score of at least 15, they would conduct safety reviews for every 20 patients that presented that way. And this was because they found an increased mortality in a post hoc analysis from the first NORTEST trial. So they actually, on their first safety review assessment of the first 200 patients, they did find that there was an imbalance in the rate of symptomatic ICH. So they had to terminate the study, and essentially they're reporting a phase A or a part A of the study. And then there is going to be a part B study looking at a lower dose of tenecteplase. So basically the difference in the groups is it's 100 versus 104 patients. And looking at some of the baseline characteristics, these were some of the baseline characteristics I pulled out from the results section, which I thought were important to highlight. And the three that are highlighted in red were the ones that were deemed statistically significant. And this includes age, an MRS of 0 at baseline, and then stroke-like mimics diagnosis after the patients received thrombolytic therapy. In the last part of this table, the median time to thrombolysis, I did want to highlight again because the majority of the patients, again, got the thrombolytic therapy before 2 hours. And again, if you look at the interquartile range that's presented, the higher range of the 75% is less than 3 hours. It's actually almost closer to 2. So I would say about over 75% of the patients did receive the thrombolytic therapy within about 2 to 2.5 hours. So looking at their results, looking at tenecteplase versus alteplase, they adjusted for those three baseline characteristics that were highlighted previously. So age, the MRS of 0, and then the stroke-like mimics diagnosis. And they found statistical significant differences in all of these outcomes. And all of the outcomes do favor alteplase, which goes against some of the previous literature that we highlighted, which favors the tenecteplase. So we see that the adjusted odds ratio for all favor alteplase, with more likely to have an MRS of 0 to 1 at 90 days, with the alteplase having the higher odds ratio. Same with the major neurological improvement, which is actually something to highlight too, because this was not always seen in some of the previous alteplase trials as well. Any ICH, there's a rather high rate of ICH in this group, similarly to the first trial that we highlighted, the phase 2 study that showed about a 26% ICH rate. And then for symptomatic ICH, they did not find any difference, statistically significant difference. It was 0.06 was the outcome difference, but they did find 6% overall incidence in the tenecteplase group versus only 1% in the alteplase group. And this may be a clinically significant difference that would maybe push the tenecteplase dose of 0.4 milligrams per kilogram a little bit more in the rearview mirror. And then for the ordinal shift analysis, more patients were actually likely to achieve a score of 2 or greater with the tenecteplase group at 90 days compared to alteplase. And then again, they actually also found a mortality difference with tenecteplase being a higher odds ratio for mortality. And I did want to highlight the image below, looking at the breakdown of the individual scores on the MRS scale. And if we look at the first three, the MRS of 0, 1, and 2, we find that the absolute difference in the two groups always favors alteplase. And then when we look at the scores 3, 4, 5, and 6, which in some studies would be deemed as a non-favorable or unfavorable functional outcome, the absolute difference again will favor alteplase, but because they're lower, you would think that they're having a better outcome. So tenecteplase had less favorable outcomes and then more unfavorable outcomes as well. So for the author's conclusion, tenecteplase at a dose of 0.4 milligrams per kilogram is not non-inferior to alteplase for the treatment of moderate to severe ischemic stroke. They did point out that the rates of intracranial hemorrhage, poor functional outcome, and mortality were higher in the tenecteplase group, and the tenecteplase 0.25 milligrams per kilogram may be an optimal dose for the treatment of patients with moderate to severe ischemic stroke. So some of the strengths and weaknesses that I'd like to highlight for this study. One of the strengths is that this is a patient population, again, that we haven't totally studied with tenecteplase. So the NORTEST trial The median NIH stroke scale was about 5, so including majority of the patients with mild acute ischemic stroke. And then the Extend IAT&K trial highlighted more of the LVO population, but this study does highlight all moderate to severe acute ischemic stroke patients. They did include wake-up stroke patients, which I did find to be a strength of the study, because again, that is another topic of discussion for thrombolytic therapy for these patients. Although the incidence of those patients in the study was rather low, both less than 10%, if I remember correctly from the results. Again, another strength, because of that safety analysis, after the 200 patients were enrolled, they did highlight that difference in the ICH scores or the ICH rates. And this did lead to the study being basically ended and conducting a part B, which is another strength of the study, looking at that 0.25 milligram per kilogram dose, comparing that to Alteplase. And the last strength I'd like to highlight is the modified intention to treat analysis. And you can argue that this may actually be a weakness of the study. So the reason why I put it in the strength section is because they did an intention to treat analysis at all. So they're able to include patients that receive the drug so that it does not bias the potential safety considerations for the outcomes. But because it's in a modified intention to treat rather than a standard, this does introduce a more I like to say like author or funder bias to the study, because there is no standard definition established for modified intention to treat analysis. The authors or the funder, whoever is leading the study or the study team, can modify the intention to treat in whatever way they choose to, maybe make the outcomes look more favorable. And then for some of the weaknesses, this is where I'd like to highlight the median time to thrombolytic therapy. So less than 25% of patients received a thrombolytic therapy after 3 hours from symptom onset. So this is very similar to some of the previous phase 3 trials, where the median time was about 2 hours. And this study was more closer to 1.5 hours. So just because the inclusion criteria is about 4.5 hours, I think it's a little bit still of a question about considering that extended duration. They also did not report any outpatient medication therapies for these patients. So I think it's important to highlight what these patients were coming in on. They did highlight some of the baseline comorbid conditions, which is somewhat indicative of some of the patients we may see in the United States. But it's hard to extrapolate some of that data, because there is a difference in the Norwegian population compared to ours. And then the NIH stroke scale. So the methodology for these patients for this study was that the NIH stroke scale was assessed by a stroke competent nurse in the emergency department or a provider. And then after the patient was stabilized or underwent their intervention, that the NIH stroke scale was now assessed by a different provider again, but they're still stroke certified or stroke competent, whether it be a nurse or a provider. So there could be some variation in the NIH stroke scales, but that is to be expected, in reality and with any study as well. So it's just something to take into consideration. So some of the takeaway points that I like to highlight to wrap things up for my own conclusions. I think tenecteplase at a dose of 0.4 milligrams per kilogram should not be given to patients with moderate to severe stroke. So this would be patients that are presenting with an NIH stroke scale of greater than or equal to 6. So, I think it would be difficult to include 2 different thrombolytic therapies for any institution. So we know that tenecteplase does have some benefit compared to Alteplase, whether that be in terms of clinical outcomes or even operational. So the drug is, given over a shorter amount of time as a bolus. It doesn't require an infusion, and the dosing is it's definitely, I would say, more user-friendly. It requires a little bit less of a calculation, when we're breaking down the bolus with the infusion with Alteplase. This can also allow patients that are at outside hospitals that are not capable of providing more invasive therapies to transfer the patients quicker to another institution. Tenecteplase may be, in my conclusion again, tenecteplase may be considered in patients with stroke-like symptoms beyond 3 hours. I don't want to say that it should not be considered past 3 hours, but I think it does raise a question about the risk benefit, again, with the lack of data beyond that 3-hour time frame. And the reason why I want to highlight that too is because we all know the phrase that time is brain, and the longer that a patient goes with an ischemic tissue, the more likely that the vessels in the brain are likely to burst from whether the vessels are weak from lack of oxygen delivery. So introducing a thrombolytic therapy could predispose that patient to having a hemorrhagic transformation or just a hemorrhage in general. I think that further phase 3 studies, which are underway, are needed to compare tenecteplase 0.25 milligrams per kilogram to alteplase for the treatment of patients with moderate to severe stroke. And then additionally, I think that further studies are needed to evaluate tenecteplase beyond 3 hours of onset of stroke-like symptoms. Again, with that median time to onset being definitely before the 3 hours in the studies that were presented. So that's all I have for everyone today. Again, thank you all for joining, and I will take any questions you may have at this time.
Thanks for that nice summary of data leading up to this trial and then the breakdown of this trial. We're a little bit over time, so we have time for just one question at this point, and then the rest we can continue on Twitter. Question from Dr. Andy Webb. Is the shift towards worse functional outcomes entirely explained by the increase in ICH in the TNK arm, or is there something else going on there?
Yeah, so I think the findings that I presented for the NORTEST 2 trial, the odds ratios are adjusted for those baseline characteristics that were different. So when we think about the age being greater in the tenecteplase group, the MRS score of 0 less likely or less reported in the alteplase group, and then again the stroke-like mimic diagnosis more in the tenecteplase group, that does seem to point to a more favorable outcome again to happen in the tenecteplase group because they came in at a better baseline per se. But because the odds ratios were adjusted for those outcomes and still showed those statistically significant differences, I think tenecteplase again at that dose is contributing to the worst functional outcome. And if it's due to the ICH, I'm not really sure if that would be the only reason, but it could have a substantial impact on that poor functional outcome. Although the rate was a little bit similar to the first phase 2's trial, but again, I think it could be described by the ICH. But if it's more of an asymptomatic ICH incidence, I don't know if that's contributing entirely to the worst functional outcome.
Got it. And then I know I said one more question, but I'm going to piggyback onto that because
Sure.
it's related. So folks, I know we're over time. If you have to jump off, completely understand and feel free. But last question, did inclusion of wake-up stroke affect MRS score with tenecteplase?
I cannot remember off the top of my head if they had included like a subgroup analysis looking at those wake-up stroke patients. I think the incidence of the wake-up stroke patients that were included were minimal to have an impact on, but I think that does have a considerable effect on some of the outcomes related to wake-up stroke patients that could contribute to the different functional outcomes. So it is a confounding variable, although since there was no statistical difference in the two, and with it having a lower incidence, I would not think that it should have a major impact on the outcomes presented in this trial. Okay.
All right, folks, that concludes our Journal Club. Nicely done, presenters. And again, feel free to continue the conversations on Twitter, hashtag NCS Pharm Journal Club, and we'll see you next time.